Hello, I'm Dr. Elizabeth Coon. I'm a movement and autonomic specialist from Mayo Clinic in Rochester, Minnesota. I'm really honored to be here today and sharing my talk, Prodromal Multiple System Atrophy. I have no disclosures. And really the goal today is to highlight these early stages of multiple system atrophy, show how the Movement Disorder Society new MSA criteria highlights a new possible prodromal category, and then illustrate how maybe biomarkers in the future will help us so we can better early identify patients with multiple system atrophy. We'll go through this by looking more at motor features that are early, followed by sleep, and then autonomic. So first, multiple system atrophy. We know it involves motor systems. It can be predominantly Parkinsonism or cerebellar ataxia. Often there can be a combination of both. The autonomic involvement tends to be severe and affect a lot of different parts of the autonomic nervous system. What is unique about multiple system atrophy from some of the other atypical Parkinsonism disorder or other movement disorders is it has some specific features or red flag symptoms, if you will, that cue us in that this is multiple system atrophy. So that can be an upper motor neuron syndrome. And so that's hyperreflexia, upgoing toes, dystonia, where the muscles are pulling against each other. Often that manifests by anticollis or the head being forward. Speech is often affected. And dyskinesias can happen when patients are given levodopa, showing that it's more of an atypical Parkinsonism syndrome. Also, we know stridor and sleep issues, sleep apneas, REM sleep behavior disorder are very prominent in multiple system atrophy. Now, multiple system atrophy, as the name describes, really involves multiple areas of the brain. You can see it's really involved in the central areas, so kind of deep in the brain stem, some spinal cord, but largely stays centrally. And the characteristic neuropathologic finding is alpha-synuclein inclusions in glial cytoplasmic inclusions shown there. So when we think about prodrome to multiple system atrophy or prodromal multiple system atrophy, we think, well, what does prodromal mean? And it relates to prodrome. And the definition of prodrome then is an early symptom indicating the onset of a disease or illness. So it's really, before there's enough of these symptoms that we know or meet diagnostic criteria for MSA, but in retrospect, looking back, are some early symptoms. And one of the fantastic things, though, is if we can recognize some of those early symptoms, earlier diagnose multiple system atrophy, so when we do have a cure, better able to treat patients. So let's talk about these different pathways in getting to multiple system atrophy. So just as there is multiple areas of the brainstem affected, there can be multiple symptoms that first arise. I'm going to start first with ataxia and cerebellar ataxia. I'm going to do a bit of a background in that patients with cerebellar ataxia predominant, so MSAC, tend to see more of this in our Asian countries. So, for instance, this is really the most common form in Japan. Yet in our North American European populations, multiple system atrophy Parkinsonism type is more common. Though we still, in about our population, MSAC is about 45%, so of the patients that we see. What clues us in that this is multiple system atrophy, the cerebellar type, are often imaging findings. So of these imaging findings, we can see the shrinkage of the pons that's going into the cerebellum. And these characteristic findings is called this hot cross bun sign, showing that these pontocerebellar fibers have been affected. There's also atrophy or shrinkage of the pons and the cerebellum in the back part of the brain. So some characteristic imaging features. Now, not all patients, though, with those findings have multiple system atrophy. So those imaging findings can be seen in some of these other disorders with ataxia, specifically the spinocerebellar ataxias or SCAs. So these are inherited or genetic ataxias. There are a number of different forms of these, and some also involve autonomic involvement, like the SCA1 with orthostatic hypotension, SCA2, SCA3. in particular can really have a lot of overlap. One of the clues is that there's often a family history, and there's a bit of a different progression, which I'll highlight. But you can see in some of these patients with different SCAs, they also have the hot cross bun sign that can be seen in multiple system atrophy. So we have to do more than just the imaging to help discern between SCAs and MSAC. There also are forms of ataxia in which we don't quite know the underlying cause. And so these are termed sporadic adult onset ataxia, SAOA. In the past, they were called ILOCA, or idiopathic late onset cerebellar ataxia. And there's a lot of similarities, if you will, between these idiopathic causes and multiple system atrophy, except one of the major differences is the slow progression. This is also something that we see in the spinocerebellar ataxias, and really a normal lifespan in SAOA with minimal kind of other involvement that we do see in MSAC and in some of the SCAs. So how do we know when ataxia is prodromal MSA versus one of these other disorders? So one of my colleagues is looking at this in particular, and specifically a big group of ataxias and patients who were eventually diagnosed with sporadic adult onset ataxia, and then followed and saw what happened in the long term. And so in her work, she has found that, approximately a third to a half of patients with this original ataxia go on to later be multiple system atrophy. So what features help clue us in? So first, if the patients with ataxia have early autonomic symptoms, be it some lightheadedness, not quite orthostatic hypotension, or some bladder symptoms, not quite urinary incontinence, and that's a clue that this will probably go on to develop into MSA. Also, some of those red flag features like stridor and dream enactment behavior, which is a common feature in the synucleinopathies we'll talk about next. There's some interesting imaging features too, again, similar to what we saw in MSA. So if we can pick that up before patients have autonomic symptoms, that's a clue that they will go on to develop MSA. And with autonomic testing too, there's some differences between patients who are going to go on and develop MSA, and specifically more features of autonomic impairment, higher blood pressure drops, more of composite autonomic severity score, so worse autonomic function on those testing, and more parts of the body that do not sweat. So we're going to stay and talk about motor for a bit, and specifically Parkinsonism. And so this is common, like I said, in our population where we see a lot of patients with MSAP. And so if the early symptom is often Parkinsonism, our patients are often misdiagnosed with Parkinson's disease before MSA is truly uncovered. Now, the Parkinsonism in MSA can look very similar to Parkinson's disease, in that there's bradykinesia or slowing, rigidity. What's a little bit different is that in Parkinson's disease, there tends to be more one side involved. There's more asymmetric, where in MSA, there tends to be a bit more of symmetry, but that's not a rule. Also, the tremor that we see in MSA can often involve the hands when they're outstretched, and that would be pretty rare in Parkinson's disease. And there can often be myoclonus, or sort of brief jerks, and that would be more common in MSA. Also, I mentioned that anticallus, that is more of an MSA feature. And usually patients with Parkinsonism are prescribed dopaminergic agents to try and increase dopamine levels. But usually patients with MSA do not respond as well, or they don't respond as long as someone with Parkinson's disease would. So maybe there's an initial response, and then there's severe dyskinesias, and the response tends to wane. That said, a lot of patients still gain some improvement from levodopa and may stay on that. The imaging findings in multiple system atrophy, the Parkinsonism type, tend to show this white rim, this T2 hyperintensity outside the putamen. You can see this is slightly asymmetric, worse here on the left. And then on our gradient echo, or sometimes in our susceptibility weighted imagings, we see this low signal also around this lateral edge of the putamen, which is a clue for multiple system atrophy. Now, I want to highlight then some differences between multiple system atrophy and Parkinson's disease, which patients may be earlier diagnosed with. And specifically that in Parkinson's disease, the areas involved, again, kind of similar in these areas in the brain and spinal cord. But what is very different is in Parkinson's disease, there's Lewy bodies. They tend to involve the ganglia and the effector organ. So at the heart, at the gut. That is different from MSA, because recall, really, there weren't those glial cytoplasmic inclusions in these areas. So when we're trying to decide between Parkinson's disease and MSA, we know Parkinson's disease is common. There's the classic features that can overlap with MSA, but patients really should respond to dopaminergic therapy like levodopa. And patients with Parkinson's disease often can have autonomic symptoms. They can have constipation. The bladder symptoms tend to be more frequency and urgency, more of an overactive type bladder, whereas the bladder in MSA tends to be more of a urinary retention picture. But orthostatic hypotension can be so common in our patients with Parkinson's disease, and levodopa actually can worsen that too. There can be some sweating dysfunction too, but it's usually a different degree than what we see in MSA. For instance, in Parkinson's disease, sweating or too much sweating, hyperhidrosis tends to occur as patients are coming off of medications. So what can we do to really sort out patients who have significant autonomic failure from those with multiple system atrophy? So again, those red flag features that I highlighted above, the fast progression, more so in MSA, and the urinary retention rather than the more irritative type bladder symptoms. Also, cluing into what part of the brain and the nervous system is involved and where those Lewy body or the pathology lies is looking at the norepinephrine levels. So if a patient with Parkinson's disease has autonomic failure, we'd expect those norepinephrine levels to be low, whereas because MSA is a central disorder, the norepinephrine levels tend to stay high when checking catecholamines. I highlighted some of the brain MRI findings, but also knowing that the heart is involved with Lewy bodies in Parkinson's disease, patients with Parkinson's disease or Lewy body disorders can have abnormal cardiac imaging with a specific tracer termed MIBG. Now, this is not covered so much in our US population, so it's rarely done, but it's something that is seen more on the research side. So I talked about those red flag features. Again, that upper motor neuron syndrome, the speech also is different in Parkinson's disease versus MSA. So in Parkinson's disease, the speech is soft, quieter, slower, more mumbling. But in MSA, there's also more of a spastic or a hoarse quality to it as well. The dystonia can affect the neck with anticols, but it can also involve the hands, can make the toes turn in, the toe go up, and then also the cold hands and feet, often with a purple or reddish discoloration. And then stridor, the type noise that can be heard when patients are sleeping. So next I want to talk about sleep. And so there's some clues that from the sleep world about the pathway to MSA, and specifically REM sleep behavior disorder. So REM sleep behavior disorder is very common in all of the synucleinopathies, so multiple system atrophy, but also its cousins, the Lewy body disorders, Parkinson's disease, dementia with Lewy bodies. And so with REM sleep behavior disorder, with REM sleep, there should be loss of tone. So really muscles should not be active with REM sleep, brain's dreaming, it's not acting out those dreams. But in REM sleep behavior disorder, that loss of muscle tone is not present. So then patients do act out often vivid dreams. Now, as some of these brainstem areas and brainstem circuits are likely affected in REM sleep behavior disorder. And one of the interesting things is that this REM sleep behavior disorder and this connection with synucleinopathies has been known for quite some time. And so some of the early kind of description is that patients with Parkinsonism, about 40% of the time, kind of had REM sleep behavior disorder beforehand. But now we know that it's estimated up to 90% of isolated REM sleep behavior disorder will eventually develop into one of the alpha-synucleinopathies. So this has changed the concept in how the field thinks about REM sleep behavior disorder. And so now there are specific stages, And knowing that REM sleep behavior disorder occurs on average about 8 years before some of the features of motor or cognitive features that lead to the diagnosis of Parkinson's disease or dementia with Lewy bodies. And so normally, patients may have just some mild movements that doesn't quite fall into the category. And then there may be some prodromal REM sleep behavior disorder, doesn't quite meet the criteria. And then isolated REM sleep behavior disorder means REM sleep behavior disorder has been captured on polysomnography, but there are no other motor findings or cognitive findings. And then later we see more of these signs that fit with the overt synucleinopathy. So it's really exciting to think of, well, if we can pick up patients earlier in this stage, then there's maybe a chance to act. Now, I want to highlight pure autonomic failure. And so in pure autonomic failure, there's really isolated autonomic features, and we'll talk about how that can go on to MSA shortly. But the tricky thing is that dream enactment behavior doesn't always start before the pure autonomic failure or the orthostatic hypotension symptoms. So sometimes this dream enactment behavior does come later, which makes it a bit harder to use as a clinical biomarker, if you will, for this diagnosis of MSA. So next I'm going to talk about pathways to MSA and the autonomic failure that we know that can be so severe in patients with MSA. There are often multiple areas of the autonomic nervous system affected in MSA. So quite commonly, for the diagnostic criteria, it's really centered on orthostatic hypotension or the blood pressure drop. Often with that blood pressure drop, there is corresponding supine hypertension when patients are lying flat. That blood pressure can also be very high. Sweating is often affected, and anhidrosis with multiple areas of the body not sweating. This is something that patients don't always pick up because the lack of sweating isn't always noticed. But if there are still a few areas of preserved sweating, they may be overactive. And so if there's any sweating symptoms, look for clues of anhidrosis to make sure that patients stay safe in the heat. Bladder symptoms are also very common. And I mentioned urinary retention tends to be the key in MSA, but often it can start with more of an urgency and frequency type picture before urinary retention. And I've starred this because the MSA criteria uses bladder then as for diagnosis. Sexual dysfunction is common in both men and women. And on the GI standpoint, there tends to be more constipation. Those cold hands and feet we talked about, often with color changes, is a unique feature of MSA. So now let's do a case, and we'll talk about more of the autonomic involvement. So this was a 56-year-old woman who came into the clinic because she passed out. In getting the history, there have been about 3 years then of some subtle things that now we think were important. So she'd had a few episodes where she lost control of her bladder. She counted it to waiting too long. But then one of them just happened, and she just popped up off the couch and realized she lost control of her bladder. And then she was having more lightheadedness, especially once she was getting to the top of the stairs or if she squatted down looking for something. And her partner reported that she had a history of acting out her dreams, sometimes violently jumping out of bed, thinking people were in the house. On her examination, she was fully normal motor examined, so no Parkinsonism, no ataxia, no motor signs. And cognitively, she was doing quite well as well, with an almost perfect score on her Montreal Cognitive Assessment. So we checked some laboratory values, and that supine norepinephrine was in the normal range. Upon standing, it didn't quite double as we wanted it to, but they weren't on the low side. In doing the orthostatic vitals in the office, you can see she has both supine hypertension and then a significant blood pressure drop going from seated to standing. On autonomic function testing, we see evidence of autonomic failure with this absent late phase 2 on Valsalva, a prolonged blood pressure recovery time. There's also a reduced Valsalva ratio. And then on tilt, we see this gradual drop in blood pressure over time with really a flat heart rate response, something characteristic of neurogenic causes of orthostatic hypotension. She had really excellent sweating on QSART, but this included over some areas that were a little light. About 11% of her body didn't sweat or was anhydrotic on the sweat test. So this woman met criteria for pure autonomic failure. What is pure autonomic failure? So it classically is defined by more peripheral alpha-synuclein occlusion, so a bit different than multiple system atrophy. The key feature is orthostatic hypotension with a tendency for significant blood pressure drops or syncope. There often can be that supine hypertension that goes along with the orthostatic hypotension, and multiple areas of the autonomic system are involved. So often with constipation, genital urinary failure, and then often very severe anhidrosis with some of that compensatory hyperhidrosis. What's interesting about pure autonomic failure, and this has been identified for many years, is that these patients can later go on to develop motor features or cognitive features, suggesting that they would then meet criteria for Parkinson's disease or dementia with Lewy bodies or multiple system atrophy. And that was the case in this woman. So then 2 years later, she came in, and now she noticed that her hand, a jerky hand tremor, and it was consistent with myoclonus on examination, and she was having falls. Her examination also showed Parkinsonism, and she had a DAT scan, which looks at dopamine tracers. It was blunted on the left side, which fit with the right side of the body being more affected. So now at this time, she meets the diagnosis of multiple system atrophy. And this is where the question lies, well, maybe she should have been prodromal multiple system atrophy this whole time. So let's talk about this PAF conversion and what's been known. So with pure autonomic failure, when there's no motor features and there's just blood pressure drop, the phenoconversion, or who goes on to develop motor or cognitive features, MSA, PD, DLB, really has been variable. So from the lowest from our group was 12%, but then a longer study looking at that showed closer to 25%. The Kaufman group at 34%, and our European colleagues also around 32% phenoconversion. And then a smaller study from the NIH that was looking and really defined it as pure autonomic failure and did not have any central findings, as almost half of patients go on to develop Parkinson's disease or dementia with Lewy bodies. And so when we look in, our large population of patients with MSA that we have studied, so of these 685 patients, saw about 28%, so almost 30% of patients really started with autonomic onset. About 60% came in more with motor symptoms, and some had both motor and autonomic at the same time. So the current Movement Disorder Society criteria for MSA now recognizes that. So the current categories include clinically established, the highest level during life, clinically probable, and now there's possible prodromal. This is really a research category and is being further evaluated. And in this possible prodromal category, patients need to have at least one non-motor feature and one motor. So of those non-motor, that could either be autonomic dysfunction as urogenital failure or neurogenic orthostatic hypotension, or could be REM sleep behavior disorder that we talked about. But then also has to have one motor feature, and this could be some subtle Parkinsonism or subtle ataxia, and showing that there are some already subtle motor signs suggesting that these different parts of the brain are affected, and that this is different, if you will, from pure autonomic failure. So we looked at our patients with pure autonomic failure, and we had a total of 275 patients, and we looked to see, how many of these patients really stay pure autonomic failure, how many go on to phenoconvert, and we found that it was about 34 of our 67 patients, or half of the patients that end up phenoconvert end up into MSA, half into dementia with Lewy bodies or Parkinson's disease. But it's important to note some interesting features on these groups, in that the longer follow-up we had, we saw more patients going on to develop dementia with Lewy bodies or Parkinson's disease. whereas, patients who go on to develop MSA tend to do so within the first 5 years or so. So I think that's an interesting thing to note. But what we took from these patients then was to see, well, can we identify them earlier? Or what are the predictors of conversion? So when we look at the patients that stayed pure autonomic failure versus those that go on to MSA, you can see there's a lot of features that suggested they would later go on to MSA, like those subtle motor signs, that norepinephrine is high, consistent with more of a central disorder, or severe bladder symptoms, severe meaning incontinence or requiring catheterization. There are also more of these more central and autonomic features that predicted more of an MSA picture. Whereas you can see the pure autonomic failure patients who go on to develop Parkinson's disease or dementia with Lewy bodies really looked fairly similar to those that stayed pure autonomic failure, but a key feature was these subtle motor signs. So what we did from that data was create probability calculators so that clinicians with their patients, when they're seeing or diagnosing a patient with pure autonomic failure, can enter specific things into this calculator and determine the probability or kind of risk, if you will, of further or later development or being diagnosed with MSA or Parkinson's disease, dementia with Lewy bodies. This is the calculator for MSA. So if we take it for our patients, we know really she had no motor features at that initial presentation. She was seen by motor movement specialists. Those norepinephrine levels were on the high side, though, so she had a point for that. And the bladder symptoms were severe with urinary incontinence. So she had about a 50% chance or predicted that she would later go on to develop multiple system atrophy. So some other things are also being developed to try and figure out who is most at risk, if you will, for multiple system atrophy. And from our colleagues at NIH with David Goldstein, they do a lot of cardiac imaging with specific tracers. And so in a pure autonomic failure patient cohort, now these all had had more peripheral signs to be part of this cohort. They found that patients with MSA tended to have more of a preserved kind of cardiac imaging, if you will. But really, they had about half of their patients ended up kind of phenoconverting either to MSA or Parkinson's disease, dementia with Lewy bodies. But I don't want to give the impression that all patients with pure autonomic failure go on to develop MSA or Parkinson's disease of Lewy body, because there is a subset of patients that stay PAF. And if anything, we know from the literature, this is actually the majority of patients. So I think we need to really be careful in that someone may have PAF and stay PAF throughout their lifetime and not too early give them a diagnosis of prodromal MSA. So we looked at these stable PAF patients and had a median follow-up time of close to 10 years. Men were more common in this cohort and a median onset about 62 age. So kind of similar to what we see in prospective national cohorts. About half of patients had dream enactment behavior documented. And we looked at those that had it documented who did not, and they really looked the same. In terms of when symptoms come on in relation to timing of their orthostatic hypotension, you can see some patients had really early bladder symptoms, but a lot came on about the same time as orthostatic hypotension or later. Similar with bowel, the sexual symptoms as well. Sweating tended to come on at the same time or slightly later. And again, in this dream enactment behavior cohort, we tend to see more of a later onset in this group. So I'll just briefly touch on biomarkers, because now we know some clinical characteristics as patients who may be at risk for phenoconversion. What can we do to be more sure? And so biomarkers are really exciting. This is data from the Gibbons and Freeman group that has shown that phosphorylated alpha-synuclein inclusions can be helpful to distinguish between Lewy body disorders, or specifically Parkinson's disease, and multiple system atrophy. There's some of this testing that's being done commercially, but not quite at the point where it can discern MSA from PD on a commercial lab basis. And this is really some of the work from the outcomes from the studies looking at this phosphorylated alpha-synuclein in the skin. Another thing I'm really excited about is from my colleague Wolfgang Singer is the spinal fluid analysis. So protein misfolding cyclic amplification, similar to RT-QuIC, can really help distinguish between some of these Lewy body disorders with this picture here versus multiple system atrophy. And so I'm excited to see how this will change this early diagnosis, and also using other features like neurofilament light chain, which we know in spinal fluid can really help discern between these different disorders. So if we step back and say, okay, so where are we with thinking about prodromal MSA? So if we think about it from the autonomic failure route, we know that a number of patients start with autonomic failure. They often more rapidly then develop motor involvement and meet criteria then for multiple system atrophy. There's another group that has a slower progression, and these are more the Lewy body disorders to either motor or cognitive and have Parkinson's disease or dementia with Lewy bodies. But also we cannot forget that at least in our patients, the majority stay pure autonomic failure. And maybe it would take 50 years to develop, Parkinsonism or cognitive involvement, but certainly they don't in their lifetime, and that is another important thing to note, that we don't diagnose everyone with a prodromal disorder if they are going to not actually develop that disease. So I'm going to conclude and say there are multiple paths to multiple system atrophy. It likely involves different loss of neuronal populations and the different progression of the alpha-synuclein accumulation, the toxic properties that may be related to the pathogenesis. But I'm really hopeful because I think that biomarkers will be helpful for this earlier diagnosis, especially once we have better treatments. So thank you. I'm really honored to have the opportunity to speak with you, and I hope to be at the question and answer session. Thank you.